Swayam Prabha. Digital India. Educated India.
Welcome friends once again to our NPTEL MOOC module on health economics. This is the 12 weeks course where various theoretical as well as applied aspects of health economics is dealt. In this week we are addressing the supply side perspective of healthcare. Especially in the last lecture we have discussed about physicians behavior, especially physician as provider of health, and how that has led to supply induced demand in healthcare. We also discuss about their relationship with physician density, SID with supply induced demand with physician density, etc. In this lecture we will be emphasizing on another direction of supply side factor, that is hospitals and their relationship with physicians. We will be emphasizing on volume output relationship. We will also try to project and explain how the competitive structure, in this case especially it has resulted a differentiated oligopolistic structure, how this has actually impacted the relationship and eventually on the patients or the receivers. Then we will also try to model the directions of this relationship in terms of their out quantity versus quality aspects and or price versus quantity competitions, etc. In addition to that, we will emphasize on hospitals, payers, not for profit hospitals, then hospital output, etc. So, let us begin. Here we are just trying to define what is called a unit called hospital, and is it confining to only income or it's related to managerial interference. Hence a definition is defined. This is called an economic entity used by an independent medical community to support its income, where physicians could practice their profession free of managerial interference. Hence, the obvious question here is, how are the hospital or the physician services sectors separate and distinct, or do they have connections and overlap with each other? Both have simultaneous competition and interdependency. So, hence the concern here is on the competition and interdependency and how this has resulted further consequences. So, related to hospitals, we refer to their specialization and the kind of lucrative offers, services that has somewhere some linkages with our previous lecture is on SID. And hospitals cannot grow their markets shares or execute any of the new alternative payment methodologies without physician participation. A role of physicians is must so far in hospital structure is concerned, and hospitals provide income and security for physicians as well. Then hospital has two separate economic entities, that is physician staff or administrative staff, and accordingly the management of the hospitals or the prescription of drugs, etc. for the patient dealing its directions can clearly be understood. There are indeed all sort of relationships starting from the physicians to supporting staff or using the medical technologies, all are actually linked to hospitals. Broadly, there are the three types: Hospital acts as physicians' workbench, and there might be direct employees of a hospital, and physician and ownership of hospitals as well. All these lead to a possibility of problem that is called principal agent problem, and where even if all are actually defined to be good, by virtue there is an eventual outcome that is called principal agent problem, because of some forms of decisions are taken by principals and some are by agents. Though agent in this context are the main CEO or the management unit, but the principals in reality are the doctors or the staffs, especially the doctors. However, the principal role is actually bestowed upon largely upon the managerial bodies. So they used to take the decision, though the direct communication with the patient or the service receivers is lying with the doctors. So the principal agent problem lead to quality compromises and some forms of information asymmetry led troubles. So some of these might be discussed in other chapters, but at this moment we are trying to emphasize on some volume output relationship, where we just try to discuss here that the observed positive correlation between the number of procedures performed, that is volume, and patient outcomes. The hospital with larger numbers of patients with a specific diagnosis or procedure have lower mortality rates. There are indeed two hypotheses for the volume outcome relationship as mentioned by Luft et al. In 1987 paper or study. Two important hypotheses in this relationship are called learning by doing or by selective referral hypothesis. And learning by doing, we know that more the involvement or more the patient dealings or experiences are there, then that makes the system more robust, and then more learning is expected. And sometimes another aspect called the volume output relationship defined is the selective referral. So based on the experience, the referral are made and the selective cases are identified, and that is why it is called it is hence linked to the volume output relationships. The relative importance of two varies with diagnostics and procedures. Here we have already mentioned these two, especially in selective referral hypothesis. Physicians and hospitals that have better outcomes attract more patients through referrals. So there are divisions between hospital and physicians. Traditionally, both were separated by social and political powers, but physicians avoided being captured by the hospitals to maintain both professional autonomy and control over their incomes. Hospitals were initially intended to function as a doctor workshop or a physician cooperative. So even this is what largely identified through the problem of principal agent, where these conflicts arises, and physician centric model to hospital centric model is important to discuss as well. In the physician centric model, it is highly the physicians who are important, and basically interdependent physician run own clinic, and the independent physicians run their own clinic and consulting at 2 to 4 hospitals. Patients seek out doctors as their availability, as per their availability. That is purely physician led model, since physicians are actually the important driver for the supply, and because maybe due to their reputation, because maybe due to their independent working module, hence they can set up their own. Then second one is hospital centric. Based on the hospital, physicians are actually determined or demanded. In this case, hospital one, where the largely the involvement of private sector role is important, where the market based competition is driving the centric model, this hospital centric model. This focuses on returns as well, and another direction of this is on awareness about global practices. However, these two are indeed merged to a large extent, especially the physician and centric model is actually tended to a hospital centric model. The merger of these two powers is important. Hospital centric model favors full time physician model, in which a physician gives his services to one hospital or hospital for full time rather than working for 2 to 3 hospitals. So, there are pros and cons of these two. Um, uh, there are pros for patients, for physicians, for sure it is for the hospitals. Like for patients, better pre and post care advantages derived, better forecast of cost, available to doctors in one hospital at all time. Especially for physicians, the advantages are like reduced administrative burden, better work life balance, job and income security, opportunity in academic medical research, and reduce overhead cost of operation, because overhead cost of operations are taken care of by hospitals because of their merging approach. Hospitals, of course, other two categories will be a supporting hand, especially in this case. This helps focus on academics and research. The standard medical practice will improve, and a culture of patient centricity is going to be built, and more focus on specialized departments. This will generate consistent clinical outcomes. There are some con side of this full time physician model in a hospital setup. Especially the work culture might be restrictive for some, because you are supposed to go by the regulations of the full time model, and it has less autonomy, and input and opinions may not be valued enough. So, there are relationship between hospital and other hospitals as well, to derive the demand for better healthcare supply. This lies with competition, and the competition in healthcare especially is dissimilar from other industries. It is because it is not just typical competition. It's actually the competition varies because of access to healthcare is basic right in many countries, and hospitals are forbidden from denying anyone care. High barriers to, it has high barriers to entry, like building and staffing a new hospital requires high initial investment cost, and there are high standard of regulations set by government, respective government. And another directions which is important as a relations between hospital with other hospitals, that is presence of insurance distorts the typical economics of supply and demand. We will discuss all sort of things one by one. As I already discussed from the very beginning of this lecture, is about the formation of market, that is called differentiated product oligopoly. For the given special characteristics of the hospital market, only a few hospitals compete within a geographic area, that leads to a possibility of oligopoly market. Hospital market is differentiated product oligopoly. Hospitals are not perfectly substitutes to each other, and facilities may differ in two hospitals even if they have same facilities. The staff and staff experience really differ, and patients have loyalty to their physicians or surgeon, and although distance to hospitals matter. A differentiated product oligopoly is all about defined as a model of competition in which there are few firms as a result of barriers that restrict entry, and in which the products supplied by the firms are not perfect substitutes for each other. So, to understand this differentiated oligopoly, you might have read in microeconomics. To emphasize a few, this is the key. The products are actually not of perfect substitute type, there are differentiation, and because of restriction, heavy barriers to entry restrictions, very few firms are operating. So, hence the differentiated product oligopoly is expected in this healthcare market. Oligopoly in hospital markets leads to concentrated market power, possibilities of collusion, and high prices and low output, and that can be measured through the standard approaches called HHI, Horpindel-Hirschman index, and that is largely an index which is defined as sum of squares of the market share of all the hospitals in that particular market. So, in short, it is called HHI and defined as sum of squares of the market shares, and SI is actually called market share. And if the HHI index is 1, that means one hospital controls all market, that means the market hospital share is actually captured by 1. And if it is 0, that means it prevails with perfect competition. If the figures are close to 0, that means near perfect competition is defined or good competition is expected. If it is close to 1, then more monopolized or the oligopoly structure is defined. One such example mentioned by Gaynor and Town in 2013 for the US market in 2006, they found HHI in hospital markets is approximately 0.33. This indicates presence of concentrated market power, but less competition in hospital markets. Okay. So, still it is very less, the competition is there, and so this is yes, indication of some market concentration is there, but still it is very less. So, there are some estimation, other approaches of estimation you can do it to assess the competition. Usually the concentration ratio is measured, and that is in standard format called CR4 for industries concentration, and we follow HHI. Some of the papers we have referred as Mehta et al. 2016, Samjad and Hassemi 2021. So, you can also follow some data set called PharmaTrack and CMI ProS to understand the concentration, how it works for your research. We are just putting two examples for you to calculate and understand the market power or the concentration. First one is, suppose there are 10 firms in a market, and each one have equal share, that is of that is SI is equal to 10% or 1 upon 10. So, it is actually 1 upon 10. So, for each firm you have equal share. How to value, what is the value of HHI index in this market, and how we can interpret. Now, as I already told you, the market share has to be calculated as sum of SI square, isn't it? So, here you can just put it like you say SI is equal to 1 upon 10 for 1. So, SI squares for the first one, SI squares for the or 1 plus SI2 square plus SI3 squares etc. till S10 square. Okay. So, these all will be 1 upon 10 its square and so on, plus 1 upon 10 square, isn't it? So, this is basically 1 upon 100. So, plus 1 upon 100 and 10 times of it. So, 10 by 100, so is equal to 1 upon 10, isn't it? So the concentration value is actually 1 upon 10. So this means only the in terms of this it is actually 0.1. All right. So 0.1, how do you interpret this? It is very close to actually 0, which we have already said HHI level. If it is actually near about 0 value, that means the extent of competition is higher, the competition level is higher. All right. If it is close to 1, then there will be more concentration and maybe some of the firms controlling larger share. This is what we you can calculate for the first question. This is for the question number 1. All right. For Q2 you can solve it. I will just give you the hint. For the Q2, the question is little different, that um, the market is dominated by some of the firms. Suppose instead of the first example, one firm, we have just mentioned one firm in this market dominates 90% of the market share, okay, and remaining 9 firms controls or have the equal share. Okay, so one is 90%, okay, and others are actually same, or that means other 10% share is actually divided by other 9 firms. So 90% and its square plus then other 10% divided by all 9 and their square, you are supposed to just add it and you will find the value. So in this case it seems very clearly you will find a value that will be close to 1. Okay. I am just giving you a hint, you can just calculate instead of 1 and 1 upon 10 every time and its square, it will be 9 by 10 for the first and others are very less, and you will get a value very close to 1. Okay. So if that is the case, that means the market concentration is very high, and this seems the market is controlled by few players. So after deciding the market capture or the market concentration, we have some other directions called the competition, the trade off between price and quantity competition. Price competition means I mean, whether price competition should follow or quantity competition should follow, that depends on the kind of structure the healthcare a country is having. Usually as I already said, there are strong market barrier for entry in most of the countries in the world. We start with the basic example of UK versus USA. One is mostly government controlled or the public controlled, and the other is privately facilitated or privately or market oriented, the US one. Now given this backdrop, whether this leads to more of price competition or more of quantity competition, just the single answer for it is that where if it is largely regulated and or the facilities is largely provided by insurance, okay, where moral hazard problem really works, role of price really does not matter. Okay. So no price competition because it is mostly regulated and price is eventually near about same. So a price competition where to some extent possible where co-payments are given. Okay. Co-payments we already discussed in our earlier lectures or in different weeks, especially we discuss in insurance market. And now it lies with another direction called quantity competition. Hospitals compete on quality by adopting the best medical technologies available to appeal to physicians and their patients. This has resulted largely for the hospitals to accumulate the best medical technologies to influence demand, and And this also leads to some overconsumption of medical technologies as well, because of the competition that has driven for the accumulation of quantity, different forms of quantity, or to differentiate their quality. They are in a race actually. That race is called medical arms race hypothesis, mentioned by Dranov and Satterthwaite in 2000. And if supply induced demand is present, then medical arms race may harm patients by increasing their medical consumption and hence their health expenditure, because the in the race of accumulating more technologies that will drive unnecessarily the demanders through the supply, and eventually it will result in higher medical consumption and expenditure. Okay, and that's one important directions um, for the research. Positive competition has higher cost correlation. Okay, so you can just see and try to prove in your own work. And coming to hospital competition and patient outcome, to some extent we discussed, there are actually ambiguities. In the standard practice, more competition leads to improved welfare. However, in hospital market, the literature suggests ambiguity in result, because some suggest worse morality rates in more competitive environment, and some also suggest competition improves welfare for patients. And ambiguities have motivated government in some countries to regulate the hospital industry by rationalizing hospital industry and eliminating private competition. So now some other relationships are important, like hospitals and the payers related to hospital bill and cost shifting, etc. In terms of uncompensated care, hospital costs that are not covered by out of pocket payments, public insurance or even private insurance. In that case, the relationship really matters. Then it is questioned as who pays for uncompensated care. Indeed, nobody. Government may provide subsidy or relax taxes for compensating their cost. Cost shifting sometimes occurs due to the cross subsidization. We already discussed, the richer one might compensate. That exact word is called cost shifting. And hospital may also charge more from lucrative services, may also subsidize in other cases. In nationalized system, cost shifting occurs at tax collection level as well as through progressive tax structure. Non-profit and hospital production, equity is a concern, and everyone should have access to basic health care. Why the question is here is that why do the non-profit hospital exist? Private hospitals divided into four profit hospitals and divided into the private hospitals largely divided into four, maybe for profit hospitals and maybe for not for profit hospitals. So cumulative cost of care at not for profit hospital is lesser. For profit hospital account for 55.3% in patients, while not for profit hospitals account for only 2.7% in patient care in Indian structure as identified by Sarwal 2021 study. Hence, there are four aspects largely discussed. One is called government failure theory. Then another is called altruistic motive theory, then asymmetric information and a failure of trust theory, and non-profit as for for profit in disguise. Government failure theory, where non-profit exists to satisfy the demand for charity care above and beyond what the government provides. An altruistic motive theory, where some entrepreneurs have altruistic preferences such as maximizing output, not profit, and organize non-profits to achieve them. And asymmetric information might create distrust And non-profit exists because donors cannot observe how for-profit will use their donations and do not trust them. And the last one for non-profit is profit in disguise, where non-profits are profit maximizing firms taking advantage of the legal benefits, especially for non-profit status such as tax evasion, etc. Okay. And here in Indian case, non-for-profit hospitals, sometimes the premises are different in different setups, in faith-based hospitals, community-based hospitals, cooperative hospitals, private trust hospitals. These basically the classification in Indian context is largely on 4 aspects which I just said, these 4 indicators. You can see the differences, and if you see faith based, selfless service to the society as service to God, whereas in community based, selfless service to the own privilege of the society is the point. In cooperative case, self sufficiency in healthcare, whereas in private trust, the service rendered on a no profit and no loss basis. So far as founder perspective is concerned, there are also differences, and you can just see from their work by Sarwal et al. And last couple of things to explain here related to challenges faced by not for profit hospitals in terms of recruitment, in terms of reimbursement, funding and compliance burden. You please go through these aspects. I am sure you will find the difference very clearly. And coming to hospital output, it is really difficult to measure and input the output of hospital services, because health is multidimensional and consists of subjective component. You cannot measure change in health before and after hospital services, and you can measure survival and complication rates, and there are other important points as well. You can just see another aspect called option demand, where customers of hospitals are not just patient treated but the whole population of its catchment area. Okay. And hence hospital output matters. Hospitals keep beds on reserve for emergency needs, maybe there is a possibility of option demand. Hence the H0 that tends to H1, that basically decided as health states if no hospitalization, and then that might be health state after hospitalization. We are just using as H1H. True measure of output of hospital services will be basically a small h to H1. Okay. So that's basically some the measure of hospital output. And output indicators of hospital activity you can just follow from like quantities of factors of production, from quantity of individual medical nursing services performed, number of patients of cases treated, and number of patient days, etc. And here we are trying to give the direction in terms of some issues such as patient days and cases treated as intermediate hospital products. So the starting with factors of productions, in our efficiency analysis unit, you will find the difference between these, the overall technical efficiency starting from a primary input to an output, where we discuss as various forms of primary inputs, and the idea is to go for minimization of cost or maximization of output, and that is largely called technical efficiency, and it has the scope for understanding of managerial efficiency and scale efficiency, and we will also discuss that in our efficiency unit. So largely we start with the output as medical services, or sometimes those also calculate use as secondary input, and final forms of output you can see in terms of their patient days and the cases treated, and In the patient days, we say nursing efficiency, and cases treated, we say internal medical efficiency, though there are also other external medical efficiency issues as well. So far as patient days is concerned, it reflects the nursing component of the hospital services, whereas cases treated we refer to as the medical component of the hospital services. So this point also clarifies how different inputs may be assigned to two components of intermediate products. So this is what we just started explaining as nursing efficiency and internal medical efficiency. So in the internal medical efficiency, we all discuss this as use of least amount of medical services possible per case. So to optimize the service. So here it's not just the output, that is patient days or cases independently. Also these two are also interlinked to define the best use, and we can derive the efficiency out of it. Especially the days spent in hospital may themselves to be considered as an input into treatment process, and this will also minimize the length of stay and leads to another forms of efficiency called as length of stay efficiency. And one of the understanding is important to mention, that is, if two hospitals treated equal number of cases in a year, is it appropriate to say two hospitals really achieved equal? It is indeed no, because there occurs heterogeneity of output, that services, hence they are not comparable. So in that case, services really categories are different. So sometimes we say beds held on reserve, and even the concept which we already started discussing called option demand, we reserve some of the beds for emergency care. Part of the hospital's factor and endowment, which is allocated to service capacity held on reserve, make number of beds or number of beds as another indicator of hospital output, how it is available for the patients on emergency or at the time of some dealing with some other securities. There are heterogeneity, as I already said, in terms of output, even if the output or number of cases dealt are same, but the quality of or the type of service is different. Treated cases differs along with along following dimensions, maybe on type of illness, severity of illness, or based on complications, stage of the disease, concomitant disease, patient characteristics, etc. Three most common patient classification systems we usually refer. One is called ICD standard, International Classification of Diseases, and diagnosis related groups, DRG groups, and patient management categories, they are called PMCs, etc. So I think I have already explained. Now I am emphasizing some of the standard referral databases and standardized categories related to disease classification. We refer to ICD. This is maintained by WHO. This provides critical knowledge on the extent and causes and consequences of human disease and the death worldwide. Latest version is called ICD 11, was adopted by the 72nd World Health Assembly in 2019 and came into effect on January 1st, 2022. This allows comparison of mortality and morbidity data across countries or regions at different times. Diagnostics related groups we refer to DRG, and patient one we refer to PMC, patient management categories. The DRG system is used by medical care and other insurance providers to categorize and pay for hospital inpatient services. This group, it groups patients with similar clinical conditions and treatment needs, and introduced in 1982. So we can compare DRG versus ICD in terms of billing and reimbursement, and for as well as ICD is for medical documentation and statistical analysis. there are some overlap as well between these two. Last one is called the PMC. This is compared to DRG. PMC put greater emphasis on concomitant diseases as well as the treatment strategies by the hospital, and this is complementary to the DRGs. Then some other couple of things to mention at the end of this lecture: comparing hospital efficiency, and this lies on barriers of entry, cross subsidization or government subsidies, and regulatory agencies as well. And then hospital efficiency can be calculated by comparison with other hospitals through parametric method and non-parametric method. Largely we use DA. We are also explaining in our respective chapter on DA, and also will give you some direction related to some conversion of the non-parametric component to parametric component, especially controlling the errors, and where hospital cost functions through the SFA, stochastic frontier analysis, will be just touched upon in our module. And measurement of hospital efficiency requires input and output, so we will be also explaining in detail. So we are explaining this in unit number 10. So these are all related to hospital, as the service provider for healthcare, and the readings we have, appropriate readings we have mentioned. In the next lecture, we will discuss about various ways of paying these healthcare providers. So the payment structure etc. will be emphasized in the next lecture. So with this I should stop here and hope you will understand and you will raise questions. Thank you.